Good evening, friends. I'm really grateful to the organizer of the ESD and particularly my friend Athanasios Papasaurus for this very kind invitation. I really regret that I couldn't come in person. I really love to come to this beautiful city in Spain. I've been asked to talk about infectious complications of stone surgery, and I'm going to spend the next 10 minutes talking about the various infective and septic complication of stone surgery. We know that urinary tract infections constitute a significant burden on the healthcare of any system in the world. If you look at the data coming from the United States, there is substantial patient and economic costs associated with sepsis, which is close to about $24 billion. Urosepsis is one of the leading cause of morbidity and mortality in the management of patients with urinary abnormalities and otherwise as well. It is the leading cause of mortality in patients with kidney stone disease, which is further complicated by comorbid conditions, significant stone burden, spinal cord injury, and other neurogenic factors. If you look at the CROWS data, it reveals that there is a low but significant mortality rate associated with PCNL, which is 0.04%. It's extremely low, but for a minimally invasive surgical procedure, it is not 0%. Well, there is a spectrum of post-operative inflammatory and infectious complications related to any surgical procedure. SIRS, which is various factors, which is basically inflammatory response, various factors, which includes the high temperature, respiratory rate, heart rate, the WBC count, and greater than 32, less than 32 PCO2, which can further get complicated by a condition called sepsis, which is twice the SIRS, if you can put it simply, typically due to an infectious etiology. This can become severe sepsis with signs of end organ damage and hypertension with greater than 4 lactate, and septic shock, which is persistent end organ failure. Now we know that stones are associated with infections, and stones are a cause of infection, and not only a cause, but stones can form because of infection. So preoperative midstream urine collection and evaluation is important. It is shown that the renal pelvic cultures are much more representative than the midstream urine cultures. And now it is clearly indicated that the stone cultures, something which is not very frequently performed in most parts of the world, are better representative of the actual cause of SIRS and sepsis post PCNL. So intraoperative stone cultures and renal pelvic urine cultures are a better indicator, and it is shown that they can direct proper use of antibiotics. The sepsis which ensues following a PCNL, and we typically treat them with generic antibiotics, which are broad spectrum, mostly covering the gram-negative cocci. However, directed antibiotics are obviously much more desirable. This may not be, the culture results may not be available for the next 72 hours, and that may be a critical phase. So it's important that we look at some of the earlier indicators of what could be the potential cause. The stone gram stains have been proposed as one of the ways. However, they cannot be relied upon to detect positive stone culture, and may lead into about 60% of unclear diagnosis. But however, when the gram stains are positive, they accurately predicts a positive stone culture in about 86% of the patient. So what about renal pelvis urine gram stain? The sensitivity and the negative predictive value is good. However, the positive predictive value and specificity is on the lower side. So renal pelvic urinary gram stain may be slightly more effective than the midstream urine. So how do you do stone cultures? There are various ways of doing it. Unfortunately, most centers in the world don't do urine culture. Typically, the stone is washed with sterile water. The stone is then crushed in a sterile mortar and using a sterile pestle. The pulverized stone is mixed with 1 ml of trypticase soy broth, and then the streaks are placed in a agar and McConkey's medium for culture studies. Typically, the results are not available before 72 to 96 hours, and sometimes it is too late. What are the risk factors? And we need to start probably think in terms of prophylactic antibiotic in these patients who have a significant risk factors for septic complication, female gender, positive urinary studies in the baseline workup, the urine leukocyte positivity, presence of infective stones, elevated peripheral blood leukocyte levels, and elevated NLRs, preoperative stent placements, and perioperative factors including multiple punctures, prolonged operating time, and postoperative residual stones are all causes of increased risk for septic complications. Some of the other risk factors including diabetes, high BMI, Staghorn stones, blood transfusion, and stone size. So PCNL and stones and infections are something that we need to be really very careful about, particularly in certain high-risk population. What about the other endourological intervention, i.e. the ureteroscopy, which is perhaps more frequently performed than the PCNL? If we look at the recently reported FLEXAR study in over 6,500 patients, the overall postoperative complication rate is about 8%, and sepsis requiring intensive care admission is about 1.3%. Some of the other studies have also looked into various life-threatening complications, and sepsis seems to be one of the more important complications related to ureteroscopy as well. This is an interesting paper which shows that sepsis requiring intensive care admission occurred in 1.3% patient in the same FLEXAR study. In over 4,800 patients, RARS was performed using a reusable scope, and we are made to think that reusable scopes are probably give a greater chance of infections rather than the freshly used disposable scopes. However, in this large database, it shows otherwise. So proper sterilization can be one of the ways of decreasing the cost of procedure by using the reusable scopes. So what are the various predictors of urinary tract infection sepsis following ureteroscopy? Almost half of the patient in this study post-ureteroscopy are related to infectious complication. So this is one of the most important complication following this minimally invasive surgical procedure. And then obviously they are cause of significant morbidity. So use of prophylactic antibiotics is one thing. Limiting the indwelling time of stents and shorter procedure are some of the ways that we can avoid sepsis following ureteroscopy. The prompt identification of various markers and early institution of therapy is highly recommended. This is the EAU guidelines on perioperative antibiotic prophylaxis, and the opening statement is that there is no clear consensus. However, for patients who've got a higher risk, 7 days of antibiotics are recommended before PCNL. However, a single dose of antibiotics suffice in patients undergoing ureteroscopy. So in summary, UTI should always be treated if stone removal is planned. In patients with clinically significant infection and obstruction, drainage is recommended prior to any intervention. A urine culture and urine microscopy should be performed before treatment. Stone cultures are most reliable compared to the midstream urine and renal pelvic, so they would preferably be done. Thank you very much for your attention.